Tonight, it is Tonight is an absolute pleasure to have the opportunity of hosting our second webinar under the refractive surgery banner. And we had one about 2.5 months ago with the amazing Dr. Dylan Joseph. And we could not wait to continue this series of webinars so that we can learn from one another, because what happens in South Africa might be completely different to what happens in Morocco, what happens in Ghana, Nigeria, and so forth. How ophthalmologists work in certain parts of the continent, including here in South Africa, might differ to what others are doing in other parts of the continent. So iAfrica Media simply just wants all eye care professionals to come together and showcase the wonderful industry that eye care is here on the African continent. By us collaborating and working with one another, we will be able to take eye care to a whole nother level and show the rest of the world how amazing this industry is on the platform, on the continent. And so without any further ado, I would like to introduce two amazing leaders within the ophthalmology profession, Dr. Rabia Moti-Ghoor, who is an ophthalmologist specializing in refractive surgery, cataract surgery, glaucoma, anterior segment, and so much more. And she's based here in South Africa, Johannesburg, at the Johannesburg Vision Institute. And of course, someone that I don't think he even remembers, but when I was doing first year optometry at the University of the Free State, I think he was doing his final year in medicine or first year in ophthalmology. I can't remember, but my first interaction with Dr. Dylan Joseph was at University of the Free State. We were fortunate enough to have the optometry department in the same building as the ophthalmology department. And so it's an absolute honor to introduce you today. Dr. Joseph is a laser and cataract refractive surgeon who is based in an amazing city here in South Africa, Knysna, at a beautiful practice. Doctors, welcome.
Thanks, Obi. Thanks for that introduction, and thank you for having me on your show and for the invite. And I hope after this evening, we will all collaborate, learn much from each other, and hope to do it again soon.
Yeah. Absolutely, absolutely.
Absolutely. Thanks, Obi. It's an honor to be here once again. And I'm delighted to chat alongside Rabia, and looking forward to discussing a good hot topic. I think there's going to be a lot to learn from each other, both optometrists and ophthalmology. So let's get cracking.
Absolutely, absolutely. Without any time being wasted, Dr. Dylan, the topic for today is how do we navigate refractive surgery complications? One of the things that has taken place is patients' awareness of surgery has obviously increased over the past couple of years. And so that comes with patients having various expectations when it comes to surgery. What are some of those expectations that patients have when they come to your guys' practices for refractive surgery purposes?
Yeah, it's a good question, I think, Obi. And with regards expectation, I think what's very important is that prevention is better than cure. Sort of dictum that I run in the practice. Expectations have to be set and met, and I think as refractive surgeons and ophthalmologists, we've got to be very, very critical with regards to the counseling and the consenting process prior to actually taking the patients through to the step of LASIK surgery or laser vision correction surgery. The expectation that all patients are good candidates for laser vision correction surgery, or all are good for LASIK, or we can manage everything with LASIK from keratoconus to astigmatism. Those are things that need to be sorted out definitively with the ophthalmologist. So those expectations to say, right, well, these are the procedures that we can offer. This is what we can and we can't do. This is what to expect during surgery and post-operatively as well. And I think the key about being a refractive surgeon is being prepared to walk the journey with that patient in the post-operative period. So say it's 1 week, 6 weeks, or 6 months. Often, for example, in presbyopes, which I think a lot of refractive surgeons don't do because it's a longer journey to walk with the patients, is to consult, counsel about blended vision, and that has a certain neuroadaptation period attached to it. And yes, there is a percentage of patients that don't adapt to it, but important part of that counseling process is show them what it's like with contact lenses first. Give them a trial. If they tolerate it, and we've got rating scores on how to tolerate a blended vision trial or not. If they tolerate it, you can consider the surgery and walk that journey with them for the first 6 or 9 months. Most people are adapted by 9 months. And if they're not, and maybe 0.5 to 1% of my patients after LASIK don't adapt, you can reverse it. So the patients need to know that there are options afterwards to change it if they are not satisfied with their vision correction. But it's all about communication, communication, communication with the patient, for sure.
Wow, that is an incredible response, Dr. Dillon, and you highlighted some key aspects. Dr. Rabia, one thing that Dr. Joseph was mentioning now was the aspect of communication. Do you find that with patients, some of them who have very high expectations or who have very low expectations, how do you guys go about managing those expectations in a manner in which perhaps someone is having this thing of, okay, once I have my eyes operated on, I'm going to see, and I will not need glasses anymore, I will not need this anymore. Because if I remember correctly, my grandmother in the late 90s, early 2000s, they had preconceived ideas about surgery in the sense that they would not go to the ophthalmologist knowing that if they go there, they're going to come back worse off than initially because someone that they know down the road had surgery before. So how do you manage those expectations, and what role do optometrists need to be playing before patients get to the ophthalmologist, Dr. Rabi?
Well, that's very important and difficult to manage patient expectations. And that was, I was actually going to add on to what Dylan was saying, that I refer to it as managing the expectations in the room. So it often comes down to the person, the individual patient. So when they walk into the room, they give you a sense of where they are at. Are they somebody who's expecting a miracle? Or are they somebody, you know, like you say, I never want to wear glasses again. And there may be the presbyope who's going to continue, a young presbyope, or there may be somebody who's just, you know, wanting an alternative and wanting to just open their eyes in the morning and be able to see. And they're very different patients. And with what Dylan was saying, the communication and talking to your refractive patient is very important, and giving them their options, explaining all the options. Because a lot of the time, most of these patients have Googled everything and they know all the options. Some of them come in there asking for a specific option, or specific type of laser refractive surgery, which may not be suitable for them. And so if I have a policy of trying to do the same every single time. So if you go through everything, all the options, and you do that in your surgery as well, you tend to miss, sort of not leave things out. And going through also the process, like in terms of optometry, like a presbyope, you've got to explain to them that you may need glasses for certain things, for the newspaper vision, because we won't get there. So telling them upfront what your issues may be, I think is often better, even when you do, we do trifocals or whatever, multifocal lenses. There's often, a lot of the time, they will need spectacles for something. And you're not really cutting any optometrists out, because I believe in co-management. So the optometrists have been seeing these patients, like for instance, your laser refractive patients, or somebody who's had laser refractive surgery and then comes for a cataract. The person who's going to help you out is the optometrist, because they may be having the files dating back to when you didn't see them, and you require all the old refractions to see how much the patient has changed, to see how much the patient has transitioned. So optometrists, for me, are a really big part of it. And just because you're doing laser refractive surgery doesn't mean that it's going to end for the optometrist, because it's far easier for them to pop into the optometrist and say, look, I've got a red eye, or something has started for me, or my vision's going down, let me have the spectacle test before then coming on to see us. And I think if optometrists know a little bit more about laser refractive surgery, and what can go wrong or about regression, they're more informed and more inclined to sort of take that role of assisting us rather than thinking it's something that we taking away from them. And so in terms of managing, what I always say is there's no lens made like the lens that God gave us when we were young. So that's what we're up against. So with any patient that comes in the practice, like I say, that we will try our best to make you as spectacle free as possible. But these are the things, and these are the things that can happen or may happen.
Wow. Rabia, to add to that as well, I think it's such an important point, and especially in the presbyopic groups, as you said, most of the time you can get a certain amount of visual ranges where there's independence of specs, but a lot of the time when you're dealing with presbyopic patients, nighttime driving, nighttime TV viewing, because you've maybe looked at blended vision, there's always that space. And that's where I think co-management is such an important role. And where I feel it would be fantastic where ophthalmology and optometry could work together is those patients that have a desire to seek refractive surgery, initially seen by the optom, the surgery gets done with the expectation that they're going to follow up regularly with the optometrist for their post-operative care. And that would be a fantastic drive if we could get an initiative together to say, right, well, let's teach you what to look out for. And we're going to discuss this a little bit later about refractive complications in terms of, post-operative folds, dry eye, inflammatory or infective reaction, and then to know when to refer, but when to actually manage that patient going forward. And they remain under the care of the optometrist even after refractive surgery. Because as he said, a lot of the time, there will be instances where they do require spectacle correction for certain distances. And that's the point, Rabia and Obi. It's about expectations. So not saying to the patient for every single visual range, especially as a presbyope, I'm going to get you out of specs or contact lenses, but these are the ranges we can look at. These are the situations that you're probably going to have a bit of difficulty in. And this is where we can sort it out with a corrective spec afterwards.
Wow.
And also asking, sorry, Obi, just to add, is what is important to the patient? What aspect of their vision do they want to be spectacle free for? Then you have a starting point, and we're going to concentrate on this and going forth and see how we can improve upon that. So that's also another thing that patients often trying to gauge what they do most in the day, what their job is, what is, a farmer is very different from somebody who sits at the computer the whole day.
Before we move on to the next question, in part of those expectations, there's obviously the aspect of finances. How does affordability then influence the decision that this will be what is best for the patient in terms of refractive surgery procedures? And when patients can't afford particular surgeries that will be best suited for them, how then do you guys mitigate against what they supposed to be getting but can't afford? And how will that then influence the complications that might arise later on as a result of perhaps not having the correct or the right surgery that was then done for that particular patient?
Who do you do?
Patient
tell
first.
us who to start.
Yeah, I don't know.
Dr. Rabia, go for it.
Okay, patient first. So as the doctor, it's usually what's best for them. And then, sort of sometimes it involves the patient saying to me, well, then let me wait 1 or 2 months. Let me, if that option is going to be better for my eye. They often, and it's not a huge range between I mean, I don't know, Dylan, like it's not a huge amount. The huge amount is the refractive surgery, and between the different types, there isn't a huge difference in payment. And
no, just ICL. I think ICL differs significantly.
In ICL it's definitely, but then there's no laser refractive surgery, and between the refractive surgeries themselves there's not much difference.
Okay.
No, I think firstly one's got to define policies and guidelines around your refractive service and what it costs, and then how long are you going to walk that journey with the patient. So that's a confidence issue in your own technology's ability to say, well, we know that the laser vision correction platforms can give you an outcome that is X, and we're prepared to look after you for Y, for no additional costing.
True.
So the patients also need to know that up front. I think medical aids, unfortunately, well, they don't. Some of the medical aids, if you've got savings, do cover refractive surgery. So when we give a quote, we always ask the patient to send it away to their medical aid to see if they're prepared to use some of their savings account. And I had a patient 2 weeks ago who had 30% of the laser vision correction fee contributed to by the medical aid. So it's important that the patient then takes that to the medical aid. There are some financing houses, medifin.coza, medifin.co.za, but I mean, their interest rates are quite significant, unfortunately. And, you know, I think some places do offer payment plans, but I mean, if you look at LASIK as a once-off procedure, so to speak, that is guaranteed or looked after, and you look at cost perhaps over the next 30 or 40, 50 years of other vision correction methods, I'm not saying one needs to draw a comparison, but if a patient is driven towards laser vision correction, what is their medical aid paying towards contact lenses, spectacles, etc., versus what is the once-off cost of laser vision correction, and how long are we going to look after that patient and prepared to enhance them free of charge? You can have 2, 3, or 4 enhancements if necessary to get them back to that target. Okay, presbyopia is a different thing, and that's that we have to explain to the patient that when that happens, we can treat that as well. But yeah, in an economic climate like South Africa, we've got to be cost sensitive, I suppose. In Europe, where I worked in Dublin, and I know in London, the cost of the same procedure, both eyes, on the same technology that Rabia uses on the VisuMax and the MEL 90, and I use on the Wavelight suite, is 3 times what we charge in South Africa. So, but it's economy of scale as well. So there, maybe the affordability of patients is more. We'd obviously like to be able to reach a base from low to high economic status, but then you've also got to take into account the running costs of those machines, which are phenomenal. Yeah, absolutely phenomenal. And so you've got to get to a point where it says it makes financial sense to do it for X, taking into account your risk ratio of running these machines and looking after your patients in the post-operative period free of charge for the next 5 or 10 years. And some clinics give a lifetime warranty.
Wow. Okay.
It is a tough question, but I think it's multifactorial, but got to do with a lot on how how much the patient can afford and how driven they are to be more independent.
All right, now I hear you. Dr. Rabi, now we've passed the stage where we have communicated effectively from the onset with the patient. We have discussed all the financial implications involved in that patient journey pertaining to the surgeries. Then surgery is done. There's a wide range of refractive surgery procedures, managing the presbyopic patient, managing the LASIK patient, managing the cataract patient. What are some of the common presbyopic complications that you guys have picked up within your practices, and how do you manage those complications that arise, for example, with specifically presbyopia? Let's start with presbyopia first, before we give an example on LASIK or cataract and so forth.
Okay, so I would say that complications across refractive surgery, whether it is grouped depending on the surgery that you have. So whether it's a myopic or hyperopic or presbyopic patient. But the difference with the presbyopic patient is, as we were saying earlier, and Dylan was saying earlier, that we cannot give them vision adequately for the entire spectrum that they did when they were like 20 years, at the age 20, and they could see everything, and they could accommodate for tiny newspaper print, and they could, search for the animal in the Kruger Park. So in terms of that expectation, it's something that has to be spoken about beforehand. And then after, you've got to deal with what vision actually they have. So if it's somebody that, they don't have, they've got to wear glasses for the newspaper. So a lot of the time, night driving is compromised because of their contrast, or because you've done, it's a patient who cannot adapt to multifocal. So you've maybe done monovision. So, their driving vision at night is not adequate. So it's addressing that specific patient's response to the lens. I mean, there's so many different multifocal lenses that we have. And with some of them, the patients get excellent reading vision. With others, they don't. And it often, what is written on paper does not necessarily happen with the patient. So I think it's addressing those things afterwards. And that's when I said, it's like the optometrist comes into play, because then, it's like, do you have a separate pair of driving glasses and a separate pair of reading glasses for fine print? Or do you have do they prefer the one multifocal lens again? Or, so all, that's in terms of complication with a presbyopic patient. Obviously, post-laser refractive surgery complications, post-cataract complications, that's things that can happen after the surgeries, no matter what age the patient is. I think. Dylan, would you like to add anything?
Rabia, I think specifically with presbyopic patients, as you say, whether it's lens-based surgery or laser surgery, I always tell the patients there's compromise. There will always be compromise. It doesn't matter whether, you're not 20 years old anymore. So as you said, you're not going to get the full range. But in blended vision, so we tend to use the word blended vision now as well, because with modern intraocular lenses, and even with adjusting your wavefront profiles on the laser, you can blend the vision so that you don't lose the intermediate or the desktop range. So with blended vision, I often tell them that the neuroadaptation period is significantly longer, and they go through 4 phases classically. Firstly, it's the wow phase. Secondly, it's the rivalry phase, because now they know that their eyes are doing different things. One's distance and intermediate, the other intermediate and near. Then there's suppression phase, which they will go through, and then blend. And those can each be an interval of about 3 months until they get this final blend. So whether you're doing that with laser vision correction or you're doing that with lens-based surgery, we always say that there's compromise, and that's going to take time. So you create that expectation, going back to your first question, Obi, that it's going to take time. And yes, I lasered a patient the other day that couldn't tolerate the blend. She waited a year, 9 months. She came back to me, says, I just can't do it. Can you make both my eyes see great for distance, and I'll wear my reading specs? No problem. But as a refractive surgeon, you've got to walk that journey and say to them, if you're not happy, how can we get you as close to happiest as we can, knowing that there is some compromise. With trifocal technology, they've come a long way. Rabia is right there. It's they've progressed in leaps and bounds. Most of them are set for certain zones, be it 30 or 40 centimeters or 50 or 60 centimeters in infinity, depending on the lens technology. And then there's now EDOF technology, extended depth of field technology as well, with some really exciting new stuff coming out, which doesn't affect your night vision. So once again, there's compromise. So you have to tell the patient, contrast and low lighting with these lenses is not as good as if sitting in good light. And night vision, halos and glare, which is a lot less than the predecessors. And you do also neuro adapt to that. So I have a at the end of the consultation, when we've decided what sort of vision correction option they're going for, we've got visual simulators, 3-dimensional visual simulators, animations that show them what blended vision looks like, that show them what your nighttime vision with trifocality looks like, and how with suppression, with adaptation, those halos get smaller and softer but don't disappear. So it gives them context that shows them, okay, I understand that this is what I'm in for. Can I tolerate it? Can I not? And there's a whole bunch of parameters that you need to look at and then say, well, are you as the surgeon then going to offer this patient trifocality or blended vision, or are you just going to correct for distance? And Rabia is right. She mentioned a point in the beginning. Not every patient is a candidate for trifocality, for blended vision. And some And that's our decision with the patient to make. And that's where the trick comes in, I think. And that you can still generate a happy patient. If you've got just distance vision correction and they're in reading specs, they can be as happy as a trifocal patient.
Wow. Dr. Rabia, with everything that Dr. Joseph was just saying right now, I can imagine that for those patients that come to you guys later on, when some of the problems that they already be having with regards to their vision is now intolerable. Now they come to you at a stage where they were supposed to have come to your practice 3 years ago. Now it's 3 years later. Does it make the potential for complications rise or become more as compared to had they come earlier on their particular problem?
Sometimes yes, and sometimes no.
Okay.
You know, so for instance, it is, I'll just take cataract surgery as an example. It is more difficult to break up a hard cataract and remove through a small incision safely than if it was softer and it was 3 years ago. And that's not to say that we, you know, to take out something that doesn't have a cataract. This is, we're talking about, you know, a vision scales where somebody waited from, you know, being loss of 3 lines and now they lost 7 lines. So yes, in those cases, it is more difficult. You know, it's with, it's not only with refractive surgery, I think it's with anything, with, you know, with any medical illness. The longer you wait, when you realize something is going wrong, the more difficult it is to correct. And unfortunately, with this COVID pandemic, that's what Adam Dinnan has seen in his practice, but that's what I've seen in my practice, that patients have waited with their normal health issues longer, and resulting in lots of complicated cases that are coming through. Whereas it would be easier to fix had they come through, you know, 6 months before then. Obviously, understanding that we're in a pandemic and the fears associated with, and it's not only ophthalmologists who are finding this, it's all healthcare, that the usual illnesses are still continuing and we're getting patients waiting longer, which makes it harder for us to treat. In terms of something like refractive surgery, at the young, well, two young patients, maybe their vision is still changing. So in that case, it may be advisable to wait a year or two longer. But then as we get closer to the presbyopic age, they're only going to have, say, you know, 10 years being spectacle free, whereas opposed they would have had 20. So I suppose it's depending on the patient, depending on the scenario, it is a yes and a no question, that some things, yes, we wait, and some things, no, we shouldn't wait. Dylan, would you like to add?
I think if you're talking about as well post-refractive patients, so patients that have had surgery already and then come back, you know, is it more difficult to treat? I think the trickiest ones to treat are the ones that have maybe left a diffractive or a trifocal technology in the eye, and after 3 years have just come for a second opinion and say, well, I don't want this lens in my eye, can you remove it? I mean, your potential for, you know, rupturing the posterior capsule and not being able to put in a secondary IOL into the bag, that sort of risk profile increases. But if they've had surgery and they drift again and they become hyperopic or myopic or presbyopic after 10 or 15 years of laser, as long as their corneas are sound and that they've got good pachymetry, good tomography, yes, we can always do a second or third or fourth enhancement as long as you're leaving enough stromal bed as well. So I think there's two sides to the coin. It depends on what type of refractive surgery they've had, and how much their eyes can tolerate further surgery, and changing their targets as well, depending on their age. So yeah, I think Rabia covered the pre-operative, and that's a bit on the post-operative side. So, but I think there's options, and it's about discussing those potential complications with the patient, and if they're happy to go with it, then that's great. We had a patient with an opacified IOL that was put in 25 years ago, and we thought, gee whiz, this is going to be difficult to remove and it's tricky, and they could end up with a lens drop and vitrectomy, and the lens slipped out the bag. It just slipped out easily, and you put in a 3-piece. So that case was fine. But on the other hand, Another case may end up with a dropped lens. So you've always got to be very careful, and the sooner the patients approach you with their problems, the better. But that's why it's all about communication, and we follow our patients up regularly. One day, 1 week, 6 weeks after surgery, 3 months, 6 months, a year, depending on if it's LASIK, PRK, or lens exchange. They get followed up regularly. So we can discuss the problems face to face, not with a technician, not with another consultant in the office, with the person that did the surgery. That's it. Most important.
Wow, you've both highlighted some valuable tips here. And one thing that I'm realizing is that as an optometrist, we have such a massive role to play. Firstly, we are the ones that are seeing the patients first off before they get to you guys. So how are we communicating with our patients needs to be somehow in line with how you guys communicate with your patients, so that there is that continuity when they get to see you guys. Yes, we're not diagnosing, but some of the things that you mentioned in terms of where a person or a patient sees currently versus where they're supposed to be seeing versus where it is possible for us to take them to be seeing, whether it be through glasses or surgery or any other management procedures that may be involved. One thing that I'm picking up from both of you is that we need to communicate effectively, consistently, and not only beyond establishing trust between ourselves and the patient, but also making sure that there's synergy between optometrists and ophthalmologists in that patient journey from start to end, because there isn't like an end, it's a continuous process. So thank you very much for highlighting that. One of the things that I wanted to ask you, Dr. Rabia, is what are some of the factors or risk factors that may lead to potential complications in surgery? And what do you guys, or how can those risk factors be mitigated before surgeries take place?
Okay, well, that obviously depends on our history taking a lot of the time. If you're talking about problems during surgery, we need to know their medical illnesses. We need to know about previous eye infections. We need to know about how they heal with a normal scar on the hand. Are they diabetics? Because diabetics tend to take longer to heal and have a higher risk of having an infection, just simply because they're diabetic. And, are they controlled or uncontrolled? So our history taking is really important in the examination before you even sit down to examine the patient. What medication they're on. I mean, with cataract surgery, there's a whole host of there's medications, that would affect the way the iris responds to us in surgery. And if we don't know that beforehand, we can't preempt what may or may not happen. And it's always better for us to preempt what can go wrong than to have a surprise in surgery, because then we can take the steps before surgery, or adding extra drops, or using extra tools in surgery to assist us so that we don't get the complications. Dilated fundoscopy is paramount, looking at whether a lens is patient has iridodonesis, or the lens is mobile, or the iris is too mobile. All these things are important, and it's from the first step of making your incision. If your incision is not angled in the right direction, you have problems in your entire surgery. With laser refractive surgery, it's as well history taking, knowing how the patient scars. And another thing is the sort of patient that they are. So with laser refractive surgery, because it's only just a little bit of a topical anesthetic, and a lot of the time our cataract surgeries are that, but laser refractive surgery is done without sedation, whereas in theater we, often, I don't know about Dylan, but we all have an anesthetist there that gives the patient a little bit of sedation, which calms them down. We don't have that. We don't use that in laser refractive surgery. So talking to the patient and keeping them calm, and the patient almost has to be like in a straitjacket, not moving, not twitching, and they have to understand that a tiny movement of the finger translates to the eye. And if they move, the laser beam will not be focused where we need it to focus. So a lot of these complications should be ironed out, or preempting them should be ironed out in your consultation. Dylan?
Yeah. Dan Reinstein describes it very well. He's a laser guru at the London Vision Clinic in Harley Street. And he calls it
the straitjacket.
The verbal straitjacket. And he basically puts his hands on that patient's shoulder and holds them still and says, right, this is the position I want you in. So move your body and your head to make sure that you are comfortable in this position. And immediately their eyes just open up and they say, wow, okay, now I've got to sit still. But I think just to add to Rabia as well, I think diagnostics in the last 4 or 5 years has improved our ability so much to make seriously enhanced decisions about whether this patient is a good candidate for a trifocal and extended depth of field, and then even a different type of laser correction. So you can get customized laser profiles, from topography guided to maintaining the corneal curvature called a custom Q on our platform, to a standard wayfront optimized, so that our diagnostic equipment has really given us massive amount of insight and gains as to saying, right, let's try and decrease some of these risk factors to make sure that our post-operative complications, mostly in terms of satisfaction, are as low as possible. Yeah.
Wow, that is absolutely incredible. What I wanted to ask you is, as you have mentioned, the diagnostic capabilities that you guys are fortunate to be able to do right now, as a sort of like baseline equipment for optometrists, what do you believe right now in 2021 and beyond that an optometrist cannot go without that particular diagnostic technology or equipment? Because if at the optometry level, the standard of clinical care that is given, or clinical testing or examination that is given at that stage, I believe that it can prevent a lot of stuff further down the line if they are caught early. So from your guys' opinion, because obviously you guys spend millions and millions and millions of dollars equipping your ophthalmic practices, but optometrists take a different approach. So Dr. Rabi, what do you think we should be having as a baseline of equipment within our practices as optometrists?
I think that's tough. Very difficult question. What would you say is your basic equipment? And then I can add on to that.
Well, obviously, the slit lamp and OCT, right now, I'm a firm believer that having been in practice and up until end of 2019, that's what I felt like, okay, I cannot function as an optometrist without these equipment. And so, because I've seen the level of, my level of clinical ability or clinical skills in being able to identify various things in the eye earlier on, pick up the phone, send a WhatsApp to the local ophthalmologist in my area to say, hey, I'm looking at this, not sure what it is. Do you think it's something that I need to be worried about? So it has enhanced not only my clinical skills, but how I was communicating with my local ophthalmologist. So, but technology is improving and enhancing all the time. What do you guys feel that that's enough, or we can actually be having more equipment within the optometric practices?
I think one could add a corneal topographer, just the anterior curvature and stuff. It's not, something like a pentacam which is a much bigger investment. And if you have corneal topography, I think it would enhance the practice. Dylan, what do you think?
Yeah, that was exactly what I was going to say. I think I'm speaking as a refractive surgeon versus a general ophthalmologist. I think in terms of general ophthalmology, having a good skill set with fundoscopy and a fluorescence strip are two valuable pieces, along with a slit lamp. And because you can give a general ophthalmologist a lot of information with that, and maybe an eye care tonometer, or whatever. I think an eye care is slightly more accurate than most of the puff tonometers out there. And I think whether you're looking at glaucoma or retina, you know, that's going to equip the general optometric practice well enough to be able to send, and telemedicine is now big, so you could send those images via a WhatsApp, you know, and a fundus camera. Fundus camera is a fantastic instrument because it shows you the nerve, it shows you the macula, and most ophthalmologists will be able to say, right, I would rather invest in that over an OCT because it's a lot cheaper, and you can send that to an ophthalmologist and they'll be able to say, yeah, look, I mean, this is risky, or no, wait, you can see that patient again in 6 months or a year. Where I really feel that there's massive gains to be made between optometry and refractive surgery is with the topographer, as Rabia said. If the optometrists were saying, right, okay, the patients were coming in and saying, I'm interested in LASIK, can you have a look and see if I am? Oh yeah, have a seat, take a topographic image, send it to the ophthalmologist with your manifest refraction, because you do those better than any of us do anyway, to say, right, here's your data, here's your topography, your K values, and then we can get a really good idea as to whether this patient may be a good candidate. So we can save them part of the journey. And it still empowers the optometrist to say they're part of that journey. And then after refractive surgery, you go back and you can follow up topography at 3 months and 6 months and a year and annually. They don't need to come back to the ophthalmologist. So that, for me as a refractive surgeon, would be a fantastic way where we can say, this is how we could integrate co-management between refractive optometry and ophthalmology. That would be my tool of choice. But other than that, a slit lamp, a fluorescent strip, because dry eye disease is often underdiagnosed and undermanaged by ophthalmology and optometry alike. It's a very tricky one, and especially in refractive surgery, we need to know that the patient has a stable tear film, slit lamp, and a fundus camera, and a WhatsApp cell phone.
What instances would more surgery be required in managing a patient post-op? What instances have you guys found where complications presented themselves post-op that required more surgery? And before you answer that, to all the people that are joining us tonight, thank you so much. Please don't wait until the end. We've got about 15 minutes or 20 minutes or so before we wrap up the conversation. Please, if you have any question, you can do it one of two ways. Come up onto the platform and unmute yourself, unmute your video, ask the question, or you can put it in the chat so that Dr. Dylan and Dr. Rabia can have an awareness of the questions, and they can also address some of those questions that are specific to your individual practices. And another announcement, this webinar tonight was not CPD accredited, and we didn't actually apply for CPD. And I told Dr. Dylan Joseph that we're opening up the 1-year subscription of the Vision Straight CPD platform, which has 80 CPD points, to all of you at no charge. The platform usually costs 1,000 rands for a whole year. There's 80 CPD points on the platform. So the people that are joining us tonight, you get the platform free of charge for a whole year. You can just drop us the email. I'll put my email address in the chat. And I think that's a massive bargain for your optometric journey, because you'll have access to a whole lot of clinical related content that you'll be able to get all your CPD points. So yeah, I just wanted to mention that. I forgot to mention it in the beginning. So yeah, doctors, what instances would there be a need for more surgery post-op as a result of possible complications that were picked up post-op?
Myself, Rabia, who's
you can go first this time.
Okay. I think, Obi, those will be sort of classified into acute or early onset postoperative complications, and then late onset complications. I always tell my patients their biggest risk of surgery is the need for an enhancement. And depending on whether you're myopic, hyperopic, astigmatic, or a combination of the above, the percentages differ. So I give them percentages based on my outcomes and international outcomes. So they know that those are generally late onset problems, which can be managed with either a flap lift or a surface treatment enhancement. So when they know that it decreases that risk, it actually puts their mind at ease already, because they know those late onset complications, so to speak, are manageable. But my biggest issues in that first 24 to 72 hours would be postoperative infection, which is always under the flap if you've had LASIK, and on a PRK, it can be a little more tricky to manage because under the contact lens and on the surface. And postoperative inflammation like a diffuse lamellar keratitis, DLK, or CTK, central toxic keratopathy, which is very rare, but it's the worst form of DLK. So we always see our patients in that first 24 hours a day post-surgery, and often you'll be able to see if there's early signs of peripheral infiltrate or central infiltrate. Depending on that, you can manage with aggressive antibiotics or aggressive steroids if it's very early. But if you're looking at the second or third phase of diffuse lamellar keratitis, you just go and lift the flap. The patients are always happy with that. They say, right, listen, I don't want to leave this. Lift the flap, rinse it out, put them on oral steroids and topical steroids, watch them very closely, even if it's over the weekend if you have to. And if you've rinsed that out early enough, they will all be fine. Those are your biggest ones. I think early to mid to late, we call it, and that this is a whole thing about in counseling and consenting a patient is words matter. So instead of using a term like dry eye disease, we now use a term called transient ocular discomfort syndrome, which is the same symptoms of dry eye, being irritation, discomfort, redness, scratchiness, blurred vision, transient blurred vision. It is imperative, and this is where I'm getting back to optometry and ophthalmology, if we could co-manage before the surgery, manage their dry eye, their meibomian gland dysfunction, their autoimmune problems relating to dry eye. But to counsel them and say that dry eye or transient ocular discomfort syndrome up to 9 months post-LASIK can be as a result of the surgery. But if it's longer than that, it's got to do with a pre-existing condition that either hasn't been picked up or hasn't been managed. And then we need to manage that more aggressively. But fortunately, we've got a lot of really cool treatment modalities for this problem. But it's also important to watch that very, very closely in that postoperative period. And then, of course, depending on whether if you're doing a surface treatment, you have to counsel patients about haze, the risk of which is higher in the South African climate because of our ultraviolet index compared to Europe, where we basically saw nothing. And then ectasia. And ectasia risk scoring, as we were talking about earlier, the diagnostics are now so refined, and we've got so many criteria and data points to look at, including epithelial mapping, which is a big buzzword, and it's absolutely essential if you're looking at LASIK versus PRK and borderline cases, which makes it a far safer procedure, and your judgment is far safer to say whether you can do a LASIK or a surface treatment. But ectasia is one of those things that everyone is frightened about, but it's the diagnostics really do help us in make those decisions, along with what Rabia was saying about a clinical history. If you're looking at a patient with a previous family history of keratoconus, Marfan syndrome, those joint hypermobility syndromes, you've already got to be very careful if you're going to be considering a LASIK because you're weakening the bonds of the cornea. But those would be the early to mid to late complications that we need to look out for. And again, patients need to be told about those most important ones, and you need to follow them up very closely if you are at all feeling that they're a risk for those potential complications. But it's about managing them. If you manage complications, they should still have a really good outcome.
I'm just going to add about, say, the post-cataract when we would go in, and I think one thing would be infection, but that's endophthalmitis, but the risk of that is very low, but you may want to, for the injection of the antibiotics. But another thing is also if you're, a lens exchange for whatever reason, a refractive surprise, or somebody who's not adjusting to the multifocal or trifocal that you've put in, or somebody who's chosen monovision for whatever reason and can't adapt. So lens exchange is also another reason that you would. And we sort of wait long enough so the patient is comfortable with their decision, but not too long where their complication risk would be, high.
Wow.
That's just to add.
Wow, that was that was incredible. That was incredible. I think we've covered quite a mouthful of so much pertaining to refractive surgery complications, and I'm fully confident that the people that are going to be watching this, they're going to realize how we need to go out of our way as both optometrists and ophthalmologists in working together. Because when we work together, when we collaborate more, we're going to be able to help our patients far better, and that's going to improve the level of, or the standard of eye care that we are providing as a whole. So, wow, that was very, very nice. Anyone in the chat, is there any questions from the audience that you would love to ask Dr. Rabia or Dr. Dylan? I'm just putting up your, Dr. Dylan, do you mind just putting up your website on the chat? I just put up Dr. Rabia's, one of the websites on the chat. Do you mind also including your other website there, Dr. Rabia? I think I put the one on Joburg.
Yes, yes.
And just
I'm going to type it in now.
And I mean, this has been absolutely incredible. I mean, this is my notepad of just me writing as you guys are speaking, and it was such a weird experience for me, taking notes and having to concentrate at the same time. But this is, I mean, even on this page, that's the amount of information that you guys have been providing us tonight. And thank you so much. This has really been an eye-opener, because you realize that the information that you got 10 years ago is no longer the same. We need to always upgrade, elevate ourselves, gather new information on a continuous basis. So thank you so much. On behalf of Africa Media, I believe this has been a fantastic webinar. And we've got a question here. How does being from Rochelle Lawrence, the question is, how does being a diabetic patient affect refractive eye surgery?
Go for it, Rabia. I think you touched on that.
Yes.
Okay, yeah, sorry. How does, I'm sorry, my chat is only directed at one person. That's what I was trying to, but I'll do it just now. Can you repeat for me? How does diabetic, okay. So diabetics tend to have slightly slower wound healing. And that's sort of what we always need to be. So it's not to say that a diabetic can't have refractive surgery. If their diabetes is controlled and well managed, it's just something that we as, ophthalmologists need to be aware of, that their wound healing may take longer. And also some, in terms of maybe your choice of LASIK or PRK and the response to haze, you may want to stay away from things that require more wound healing. Also LASIK flaps in terms of with the diabetic and cataract surgery, so the wounds take longer to seal. So, these are things that we just need to be aware of. But if the patient is controlled, it sort of decreases the risk of any of these complications, which gives them sort of
refractive change as well. If they're uncontrolled diabetics and you're considering laser vision correction, due to that refractive change in the glucose gradient through the lens and the cornea, you can actually get varying refractions and then not know what you're lasering on. So it's imperative, as Rabia said, to have stability. There's another one from Andy.
Yes. When would you consider surgery for a young 18-year-old progressing myope? This is with regards myopia control measures. Thank you very much for the question, Mr. Andy.
Yeah, Andy, great question. Sure, there's a lot of interesting data now on myopic control studies with regards basically the hyperopic defocus on the contact lenses that they're now using. So it's not a multifocal contact lens, but they've actually got hyperopic defocus in the periphery. So the younger that they're putting patients in these contact lenses, the studies are showing statistically significant difference of slowing myopic progression down. In a contact lens, they're less likely to progress. However, with a spectacle on its spectacle plane, due to the asphericity, basically, of the light rays in the peripheral cornea, that is one of the stimulants to continue progression of myopia. And there is a large study now that shows that the younger these patients are getting laser vision correction on corneal plane, the quicker it slows down progression. We've got now age-adjusted intelligent nomograms, which will say for an 18 or 19 or 20-year-old, you will aim them for slightly plus, so plus 050. They can accommodate. And by the time they're 30 or 35, that plus 050 drifts to minus 025 to plano. And by the time they're 40, then you can consider possible presbyopic correction. So it's very, very interesting. I think myopic control up until then, it's a very fascinating new field. But I was reading an article last week on that, basically hyperopic defocus with the contact lenses. And I think it's something as optometrists to certainly look into and get involved in, because we can slow down myopic progression. And the big problem, as you know, with myopic progression is that it causes weakening in the structures of the eye. The retina thins out, they get lattice, they develop tears, they develop degenerative maculopathy. So if we can slow that down, all the better. And as soon as you can then put the treatment on the cornea or inside the eye with an ICL, the studies show, the peer-reviewed studies show that it actually controls that progression. And even if you do progress, it's usually minimal and you can enhance it.
Wow. Wow. Thank you very much for that. Mr. Peter Brower asked another question here. He said, thank you very much for the question. Actually, before I answer, I say Mr. Peter Brower's question, Mr. Andy followed up his question.
Yeah.
Would one consider surgical option?
Absolutely. Absolutely. At 18 years old, look, if they've progressed a diopter and a half, we've got to understand why they're doing that. We often do a dilated refraction as well, Andy, to see if there's a difference between their manifest and then the dilated examination in terms of their refraction stability. That often can show that the patients are either overcorrected slightly in the spectacles, which pushes them into hyperopia, which drives their accommodative state, which keeps them accepting more myopic correction. So that is often a cause of driving the myopia. So when we know, what we can do before considering that surgical correction is push them more towards the plus in a contact lens trial. But if there's not much a change, then from 18, if it's within a half a diopter to 0.75 diopters, then you can consider LASIK, a surface treatment, or ICL, depending on their clinical examination. But in a progressing myopic, it depends on how far they are progressing, how quickly they're progressing, Andy. But if the dilated examination shows that there's a significant difference between manifest and cyclo, so to say, then we've got to understand why. Are they in accommodative spasm? Are they overcorrected? Should we pull that back? And then I do that I do that with my patients in a contact lens trial, just pushing the plus in a quarter diopter, then a half. As that accommodative response relaxes, often you can get them to accept less myopia, perhaps what they did 2 years ago. And then we know that it's actually their accommodative drive that is changing that. And once you've got that number stable, whether it's at 18 or 19, then you can go ahead with surgery. But if it's progressing too quickly, we've got to find the cause, Andy.
And Dylan, you can also try the low-dose atropine for that as well.
Yeah.
To reduce the accommodation as a trial.
100%, yeah.
Thank you very much for that. Mr. Peter Brower's question was, what surgical options are there available for patients who have had RK many years ago and have drifted to become high hyperopic astigmats when they present themselves to practices now?
Mm-hmm.
Well, I have one at the moment, patient like that. And RK is the gift that never stops giving. That's how I like to put it. But they're usually at the age where they require cataract surgery. The difficulties we have is predicting the lens that we're going to put in and the formulas, and especially when it comes to toric. But putting a toric lens in, it is tough. And I think with the RK patients, there's a lot of explaining that goes into the fact that it's sort of our calculations are we're more likely to get refractive surprises on an RK patient than we are with a LASIK patient. So I think explaining that to them, and then obviously, you know, doing a, you know, in the cataract surgery, trying to correct as much of that as possible. Dylan, I don't know from your side.
So one of my favorite tools in my practice is now what's called the MS39 topographer, and it's got epithelial mapping in it. And the epithelial mapping with all these RK patients, it's essentially having had a myopic laser ablation. So they've often got very thick central epithelium and thinned peripheral epithelium. And Dan Reinstein does this a lot on his RK patients, and I've done it on a good few as well, who are specifically, Peter, higher hyperopic astigmats. The astigmatism portion is important to know. Is it regular or irregular? Is there a lot of higher orders associated with the astigmatism before we consider a toric lens? But what I do with these patients now is do a transepithelial PTK. So it's a neutral ablation profile to the thickest epithelial depth. And the thicker epithelium is in the middle, the thinner epithelium is in the periphery. So we know that by doing a PTK, say it's 80 microns centrally and 50 microns peripherally, the differential is 30 microns. Okay, on our laser platform, 30 microns equates to just under 2 diopters. So the laser on a transepithelial PTK is going to break through peripherally first. And what is a peripheral ablation going to be doing? It's going to be inducing myopia. It's a hyperopic ablation. So by the time we get down to the deepest epithelium, we have induced myopia and to a large extent corrected some of the irregular astigmatism and enlarged those optical zones, because those optical zones from previous RK patients were quite small. So I have a really cool case from George. He had both eyes done RK many years ago, and we did a standard transepithelial PTK down to deepest epithelium that took care of all his hyperopia. You've got to then account, you've got to say, you think it's going to take away so many diopters of hyperopia, and is it going to correct the astigmatism? Because now the MS39 comes out with an epithelial refraction as well. So it tells you what is the refractive status of the epithelium in terms of sphere and cylinder. So you can, just by removing the epithelium transepithelially, you can get a reasonably good idea of what it's going to do to the refraction. But once you've taken care of some of the hyperopia, some of the astigmatism, increased or improved the optical zone, then you've got a lot better picture to say, right, is this astigmatism now regular? Can I now go and do lens surgery and put a toric lens in? Knowing that you're in for a long haul, because those patients take 3 months at least to stabilize. But that so far has been my absolute go-to with these patients. And you can do, if the topography is really irregular, you do a transepithelial PTK first, wait 6 months, and then you can come back and do a transepithelial topography guided procedure to resurface some of the irregularity. So there's actually a lot that you can do with these patients, Peter. It just depends on their drive and how long they're prepared to wait, because it's often a 6 month to year rehabilitation.
Mr. Peter, does that answer your question? You can just, because he did a follow-up question on that. So I think you covered it when he said that the problem with cataract surgery is that it does not solve the problem of having an irregular cornea. So I guess you covered that in your answer. And then we've got, guys, I'm so excited that everyone now is sort of like excited and asking questions. There was asking here, Rochelle, is assessment included in the cost or is it separate? And that will be the last question.
Rabia, how do you work?
No, I do assessment first, because you never know whether the patient is, after the assessment, what you're going to find. Will they be suitable or not? Will they change their mind? Do they go away and think about it? So I work with, I do the assessment first, and then we go from there. And you?
Absolutely. We charge for the assessment. The patient has the options. And then in their surgical plan, if I know that I'm doing 2 or 3, 2 PTKs and a PRK, There's
Yeah.
one global
It's
fee
one.
for that,
That's
and
it.
I'll enhance them included in that global fee.
Yeah. So my
that-
enhancements are, yeah.
Yeah,
Same.
it's all part of the surgical fee then, but the assessment, I agree. It's a lot of diagnostics. It's Rabia's professional time and giving them opinion. So, we charge for the assessment, and then the surgery is a separate fee, but follows up with consecutive enhancements if necessary included.
Doctors,
Yeah.
doctors, thank you so much. We have to be disciplined with time. So the extra few minutes at the beginning, we've made up for it right now. But this was not going to be possible without you guys. And this was definitely not going to be possible without the audience getting involved. Thank you so much. Watch this space. This is only the beginning of what's going to be happening in eye care on the continent between optical dispensers, optometrists, and of course, our awesome ophthalmologists. And thank you very much. The recording will be published onto the iAfrica Media website within the next few weeks. Do subscribe onto the YouTube channel to stay up to date with what's happening. And if you're not following us on social media, we are on Facebook, LinkedIn, and of course, Instagram. We would love to connect with you. And on behalf of the leadership team of iAfrica Media, Dr. Dylan, Dr. Rabia, we really, really appreciate this. And all the best for the remainder of the year in your practices. And keep adding the great value that you are adding in your communities, because you guys make a significant impact and difference to so many people's lives every single day. So thank you very much.
Obi, thanks for the invite. And Dylan, thanks for being an excellent co-host with me.
Well,
I
thank
thoroughly
you too,
enjoyed
Rabia. It was wonderful. Thank you too. That was excellent. And thanks, Obi, and thanks, audience. It was lovely to spend time with you guys. Till the next one.
Thank you.